Thank you. Thank you. Thank you so much for those very generous words. Let me thank Dr. Banshi Sabu and Team Diabetes India for inviting me to do this presentation. And it's really very heartening to see an entire session dedicated to oral health, which is often neglected. And we have so many diabetes symposiums. Oral health is something which, you had the odd lecture. So to have an entire session is extremely good. So the brief given to me is to basically talk on metformin and SGLT2 inhibitors on the impact on oral health. So quickly, we know that diabetes affects multiple organ systems, including the oral cavity. And poor glycemic control, as we know, increases the risk of periodontal diseases. And hyperglycemia contributes to dry mouth xerostomia and increased infection risk. And delayed wound healing in diabetics affects oral tissues. Obviously, medications play a crucial role in modulating oral health. Now, quickly coming on to metformin, which is considered to be a first-line therapy for type 2 diabetes, it primarily reduces hepatic glucose production, improves insulin sensitivity, and reduces intestinal glucose absorption, has anti-inflammatory properties, and also potential microbiome modulating effects, which has been built in detail with my previous speaker. And long-term use is associated with vitamin B12 deficiency. I'll quickly be alluding to this in the later part of the talk, and may impact obviously oral and dental health through systemic effects. Now, metformin has immense potential anti-inflammatory effects on gum tissues and may reduce gingival inflammation and periodontal pocket depth. It improves insulin resistance, as we all know, thus indirectly benefiting oral tissues. It lowers the oxidative stress and aiding periodontal healing. Reduces the level of inflammatory cytokines like TNF alpha and interleukin 6 and could have a protective role in preventing periodontitis progression. Now, in this particular trial, they showed that it was significant, where it was used, it had a huge role in prevention of bone loss during induced periodontal disease and age-related bone loss, and it significantly improved the periodontal parameters. And this was a major study which was carried out, and this was the conclusion. Going on to the second drug of focus, we come to the SGLT2 inhibitors. We have empagliflozin, dapagliflozin, and canagliflozin available in our country. The other two, SOTA and ER2, are not available. They primarily promote glucose excretion via urine by inhibiting sodium glucose co-transporters, as we know. Benefits include weight loss, blood pressure reduction, and cardiovascular protection. Increases urinary glucose, which may impact the microbial flora. Reduces insulin levels, potentially altering tissue responses. Now, not much literature is available regarding the direct effects of SGLT2 inhibitors on oral health, though it is postulated that by reducing systemic inflammation, it potentially indirectly benefits gum health. It may potentially help in reducing periodontal pocket depth. Indirect benefits through improved glycemic control and weight loss are there. And the SGLT2 inhibitors prevent reabsorption of glucose in the kidneys and thereby increase urinary glucose excretion, which is glycosuria. And this could lead to dehydration and increased thirst, and both are associated with oral dryness, which is xerostomia. Now, what are the key points that we need to know? There is a potential for dry mouth, and the increased urination caused by SGLT2 inhibitors could lead to dehydration, and which could manifest as dry mouth, a factor which could contribute to oral health issues and infections. So the importance of hydration has to be emphasized in such patients, obviously. Also, we have to remember that there is a potential risk for euglycemic diabetic ketoacidosis in patients who are undergoing a dental procedure, just like any other surgery. Also, because the patient may not be able to eat well during and after the procedure, there is a propensity for hypoglycemia to occur. So obviously the communication with the dentist has to be profound, and it is important that you inform the dentist about the usage of SGLT2 inhibitors to ensure proper management during and after the dental procedure. Now they need to be stopped before surgery ideally to reduce the risk of euglycemic DKA, which is a rare but life-threatening condition potentially, and it could be triggered by surgery, decreased calorie intake, and other risk factors. So how long to stop them? The ADA recommends stopping most SGLT2 inhibitors 3 days prior to surgery, and the American College of Cardiology recommends the same. Now, quickly coming on to oral microbiome, which has been dealt extensively by my predecessor. This plays a key role in maintaining oral health, and metformin may alter the gut and oral microbiota composition. SGLT2 inhibitors may also influence microbial changes through balance through glucosuria-induced changes. An altered microbiota can predispose to dental caries and periodontitis, and beneficial bacterial effects may reduce inflammation in periodontal disease and consequently help in management of the HbA1c also. Now, metformin, quickly coming on to the B12 deficiency part of it, is linked to vitamin B12 deficiency over long-term usage and can lead to burning mouth syndrome and glossitis and also cause atrophic changes in oral mucosa and can result in idiopathic pain affecting tongue and gums. So, regular monitoring of vitamin B12 levels is recommended in at least a certain subset of patients, and supplementation may be necessary in the long-term usage of metformin in very many patients. This was a major, database which was checked out by the Taiwan National Health Insurance, in which metformin was used in, and the risk of gingival periodontal disease was seen. So what was basically, found was that the risk of gingival periodontal disease reduced significantly in a dose response pattern when the cumulative duration of metformin usage, went up to almost 2 years, with the cumulative dose reaching approximately 700 milligrams, 700 grams. So basically, it was postulated that this was very, very helpful in the management and reducing the risk of gingival and periodontal disease. So quickly coming on to the oral wound healing part of it, poor wound healing is a common issue in people with diabetes, and metformin may have beneficial effects on wound healing. SGLT2 effects on wound healing are still under investigation. Obviously, would have an indirect effect, but direct it's still not known. Risk of delayed post-extraction healing should be considered, and obviously, good glycemic control is the cornerstone for optimal healing. A word about candidal infections. SGLT2 inhibitors, as we know, increase the risk of candidal infections due to excess glucose in the urine, and metformin may contribute via B12 deficiency, weakening the oral mucosa. So the preventive measures which are should be implemented are proper oral hygiene, probiotics, and regular dental checkups. The key points to be remembered about SGLT2 inhibitors and oral candida is that the methodology is primarily or similar. SGLT2 inhibitors work by increasing the excretion of glucose in the urine, which can trigger to a higher sugar concentration in the genital area, creating a conducive environment for candida overgrowth. And the increased risk of genital yeast infections, the primary concern with SGLT2 inhibitors is the increased risk of the infections. And the oral candidiasis potential, while less common, the same mechanism can potentially contribute to a increased risk of oral candidiasis in some individuals. So SGLT2 inhibitors are associated with an increased risk of developing oral candidiasis also, due to their ability to promote a higher sugar content in urine, thus creating a favorable environment for yeast growth to occur. Now, what are the strategies for preventing oral complications? Must encourage regular dental visits at least 6 months. And, when one is actually examining a patient clinically, one of the pointers could be halitosis, which is there, which is very often neglected by patients, by taking it as routine. Bad breath is not really considered as something bad. So that's one indicator that you should have at least a dental checkup done. And most of us are now understanding the value of definitely referring it to a dentist at least for an annual checkup, which is a good protocol to maintain. And maintaining good glycemic control for optimal oral health, use salivary substitutes or stimulants for xerostomia, reinforce proper brushing and flossing techniques, educate patients on recognizing early symptoms of oral infections, and consider fluoride treatment to prevent caries, as was just postulated by my previous speaker. Also, applications of metformin in dentistry cuts across quite a few things. It could be used in periodontitis, as I've said, it has usage in oral cancer, stem cell regeneration, dental implant, osteo integration, and also has usage in orthodontics. How it helps in osteogenesis, angiogenesis. There are clinical applications in which metformin-loaded scaffolds have broader application prospects in periodontitis, tooth cavity, and other craniomaxillofacial defect in patients. The pathway is via the MPK pathway, which I'll not go into details, but these are the postulated effects, which the benefits which metformin ensures. What are the future directions? More studies needed on metformin's effect on oral microbiota. Long-term impact of SGLT2 inhibitors on periodontal health remains unclear as of now. Potential benefits of metformin in preventing periodontitis has been clear. Investing SGLT2 inhibitors induce changes in oral immune response is there. Role of personalized medicine is extremely important in diabetes and oral health care, and emerging therapies that may benefit both diabetes and oral health need to be seen. So thank you very much for a patient hearing.
Thank you for a wonderful presentation, sir. I would like to ask you, sir, many times in dental treatment, extractions and periodontal surgeries are done, and also we prescribe analgesics. Now, in light of the patient who is already a diabetic and is on either metformin or SGLT2 drugs, would you recommend any change in protocol in the analgesics use or antibiotic use?
Where diabetes is concerned, obviously the primary thing is to see that if it's not some kind of an emergency procedure, obviously the diabetes control has to be optimal. I don't think that there is any contraindication to the usage of NSAIDs in such patients. Obviously, with the usage of these drugs, the things that I talked about need to be taken into consideration. And if there is any kind of a problem and the patient is not really controlled, and if you have ample time on hand, at times it may be prudent to shift to basal bolus insulin therapy to give the patient a better outcome. So that all depends on the clinical scenario, whatever the patient is presenting with. Antibiotics, I don't think there is any contraindication to usage of anything. It just depends on the profile, and if, at times, if you see that the infection is not uh, kind of healing up, obviously cultures need to be taken and checked, and initiate the appropriate antibiotics. NSAIDs, like I said, I don't think there's any contraindication to usage of any one of them. Yes, you have to see it in context of the others, how much the patient can tolerate, because the patient as it is being sick may not be able to tolerate a higher dose of anti-inflammatories, acidity and other things may happen. So that's what's basically considered.
Thank you. I think one of the
Those are, like I said, the clinical consideration per se, those things are there. If there is a particular comorbidity or a clinical condition, obviously, if the patient is having CKD, giving NSAIDs is by and large out of the question. For from the perspective of further deterioration of renal function, etc. What I'm talking about is a reasonably stable patient, and then you could go ahead.
Thank you, sir. Thank you for the insight. One of the key takeaways is that not only it is important that to know the diabetic status of the patient, but also equally important is to on what drugs the patient is.
Yes,
Thank you, sir.
absolutely.
Thank you, sir.
Thank you.
And thank you so much. I have also gone through an article in which the patients with diabetes have resistance to analgesics. So some basic analgesics don't work very efficiently in patients with uncontrolled diabetes. So that's also what you should take care of. Thank you. Yes. So, so next speaker is, let's put our hands together for Dr. V.V. Ramakumar. And soon you'll come to know which topic he's going to speak on. And he is MBBS and diploma in diabetes, Croatia, TDC, NP, FIDF Sweden, FDI, FR, SSDI, the degrees he holds. He's a Mary Jane Mills Scholar, 1998, trained at Gosling, USA, Karolinska Sweden, Steno, Denmark, and the Joint Secretary, SSDI. Faculty RSSDI Diabetes Impact Recon APDI. He's a certified trainer for diabetes educators, certified laughter yoga and testing, promoting laughter in national and international conferences. We would like to have this session also, sir, with you. Sriya Diabetes Care Research Center, Guntur, Andhra Pradesh, India. Welcome, sir.
Okay. At the outset, I thank Diabetes India for giving me this opportunity to be with you all. And mouth is very closely related to diabetologists because we have to tell them not only to keep their mouth clean, but they have to control whatever they are eating. So mouth plays an important role in diabetes control because unless they control their mouth and diet, we can't control diabetes. So mouth is very important. Madam already explained what are the problems with that. And my topic is there sufficient evidence to support the use of salivary biomarkers for diabetes monitoring? So if you want to monitor diabetes, we can use saliva. So you should go to your biochemistry. What are AGE, advanced glycation end products? Advanced glycation end products are proteins or lipids that become glycated as a result of exposure to sugar. So you are measuring a protein which was added by glucose, or glucose is added to them. That is HbA1c. What we do, they are a biomarker implicating in aging and the development of or worsening of many degenerative diseases such as diabetes, atherosclerosis, chronic kidney disease. So in chemistry, an adduct is a product of a direct addition of two or more distinct molecules. So here glucose is added to proteins that we were measuring, and glycosylation is the reaction in which a carbohydrate, that is a glycose donor, is attached to hydroxyl other functional group, another molecule, in order to form a glycoconjugate. So this is what we measure routinely to know. So the glycation or glycosylation will cause the indirect measurement of glucose. So this is how they do that. SMBG is self-monitoring a blood glucose one day, and glycated albumin, where glucose is deposited on the albumin, we measure that, and HbA1c you know. So this is how we measure, and what they say is increased glycosylation correlates with hyperglycemia. So if you can measure your glycation or glycosylation products, it can show you indirectly how your diabetes is controlled. So this is an article, salivary protein glycosylation as a non-invasive biomarker for assessment of glycemia. So we can assess the glycemic control with saliva. So this was a study done by our senior diabetologist, Professor P. Rao, and they found out that this is how they do it. They take a swab and put it in the mouth, and they change it into syringe and they squeeze the saliva, and that saliva is measured. So salivary protein glycosylation levels were measured using the method developed to preferentially detect sialic acid and fructose, as these are major monosaccharides found in secreted glycoproteins, and our preliminary studies demonstrated that saliva reactivity to sialic acid and fucose binding lactins was correlated, and both are associated with hyperglycemia. So what they say is, in this study, salivary glycosylation measures correlated with the level of glycemic control in type 1 and type 2 diabetics. The degree of variation across time in participants with poor glycemic control indicates that salivary glycosylation measures are more sensitive to short-term changes in glycemia than HbA1c or fructosamine. Salivary glycosylation represents an alternative non-invasive method for monitoring of glycemia. Till now, all these methods are not FDA approved. There are methods we can measure direct glucose also, but it is also not FDA approved. So what they do is, I told you already, salivary glycosylation, it represents 1 to 2 weeks of blood glucose control, and point of care technology, chemistry to measure salivary protein glycosylation. There are methods available. I came to know it's not yet approved. The glycheck test uses specific chemistry to detect the carbohydrate component of salivary glycoproteins. Diabetomix, they developed this. So easy to use non-invasive test, 2 to 5 minutes to read from the drop of saliva.
and test once 7 to 14 days, because we are measuring 7 to 14 days blood sugar, and provides a quick estimated average glucose values to monitor treatment. So these are the advantages: painless, point of care, protein based, pathobiologic, short term diabetes control can be measured with this. So these are all the differences how this glycosylation versus glycation. So what I want to tell you is, non-glycosylated protein looks like that. When sugar is added, then it becomes glycosylated protein. And normal, how this low glycosylation, it is normal. If there is disease like diabetes, there will be increased glycosylation. And if you treat them properly, you will have reduced glycosylation. So these are the salivary protein glycosylation as a non-invasive biomarker for assessment of glycemia. They came to a conclusion that salivary glycosylation assessment correlated with weekly levels of glycemic control. The degree of variation across time in participants with poor glycemic control indicates that salivary glycosylation measures are more sensitive to short-term changes in glycemia. Salivary glycosylation represents an alternative, non-invasive method for short-term monitoring of glycemia. So this is how they do this. I told you already. So glucemia. This is the glucema uses specific chemistry to detect sugars on salivary glycoproteins. I explained already how it is normal, disease, and treated. So this is the instruments. They are not at FDA approved. They are doing research. I called P. Roger and he says that it's not yet approved and they're trying. And it's a future, because most of the patients, they don't like to give their blood. But if you can use saliva, that's very useful. So we are waiting for these tests to be FDA approved and better, have better, what you call, evidence based, then we can use these things. Till then, we have to go that normal way. And I hope my patient, if I come, my patient comes, take a swab and test, that will be very useful to them. SMBG and now CGMS, they are useful, they are non-invasive. So they compared this with that and they found out it's good. Okay, thank you very much. And what I want to tell you is, so these I searched for the whether they can measure glucose directly from the saliva. There are some problems with that, and FDA is not yet approved these instruments. If we can get, that will be very good. Now I want to tell you about smiling, because I promote smiling. And so Dr. Smile Club, we started that, and Smile Diabetes Research Trust we have. So if you smile, smiling makes us more attractive. Smiling exudes positivity. If a person smiles, it's positivity. And smiling is infectious. Smiling reduces stress. Smile brighten another person's day. Smiling can lift our faces and makes us look younger. I tell my female patients to smile, so you no need for makeup or lipstick. Smiling is a natural drug, and smiling denotes forgiveness and openness to forgive. And smiling allows us to appear self-confident. They say that if you're smiling, you, and smiling brings us close to our friends and family. Usually, people who are smiling, they are liked more. So we started this Smile Day. We are celebrating, and we conducted this program, how to improve smile in diabetics, including our IDF president. All are involved. So we want to promote smiling in our day-to-day practice, because smiling can make things better. Particularly if a patient comes and if you smile, it will be very useful, because when we are very much burdened with our routine practice, and we will be very serious. But if you start smiling to your patient, it will improve a lot. So research has shown that laughter yoga has many benefits, where they laugh voluntarily to get more benefits. But I don't advise that. But at least smile with your patients, spend more time to laugh with your patients. I mean to say, smile and be friendly, be courteous. I believe that patients need the most smile in their life. So they waited for so long, 3 hours. Some people maybe morning till evening they are waiting, and when they come inside, you should give a smile and give them something positive message. Keep smiling, and let us smile together. Let us laugh together for 30 seconds. Are you ready? Okay. Very, very good. Hari. So take more time to law. Thank you very much.
So thank you so much. Your presentation again brought smile to my face. I don't know about people. Did you enjoy your presentation? Okay. So
Thank you very much, Raman sir. Actually, we are smile makers, and we believe in healthy smiles. And dentists always say molar to molar smile. So we definitely are few of the people who are responsible to bring smiles on people's face. Thank you for this wonderful lecture. That is the subconscious response. Yes.
So you will get all of it, even if you fake it. So try to fake smile at least.
I would like to request and welcome our next speaker, Dr. Priya Phatak. Dr. Priya Phatak has done her bachelor's in dentistry from AMC Dental College and Hospital and her master's in public health in biostats. These are her some of the publications which we can see, and she has done this from the School of Public Health and Health Policy. That's right. Yeah. CUNY School of Public Health and Health Policy. Right. And the topic that she would be covering is a debate, and she would be speaking in favor of the motion that is, should periodontal therapy be standardized as part of diabetes management plans? Over to you.
Thank you. Thank you to Team Diabetes India for giving me this amazing opportunity and making me a part of this amazing lineup of esteemed faculty that we have here today. Today, I'm glad to present my opinion on the topic whether periodontal therapy should be standardized as part of diabetes management plans. Let me start with some stats which makes it undeniable. Periodontal disease is highly prevalent in patients with diabetes. Studies have reported a prevalence of between 46 to 90%, which is nearly double the rate of periodontal disease in patients without diabetes. Multiple international health organizations have acknowledged this relationship, including the American Dental Association. Even the American Diabetes Association has recommended that patients be referred to a dentist for periodontal examination as an essential component in the Standards of Care in Diabetes 2025. If that was not evidence enough, our very own RSSDI guidelines, penned by none other than Dr. Bansi Sabu, Dr. Manoj Chavla, Dr. Sujoy Ghosh, to name a few, have also emphasized the importance of including periodontal therapy and periodontal examination in order to achieve better outcomes for our patients. So I would just like to begin by saying that periodontal disease does not just affect your teeth or your gums. It has systemic complications involved too. In fact, periodontitis is considered to be the sixth complication of diabetes. And the bacteria that cause gum disease or periodontitis, they don't stay restricted to your gums. They enter the bloodstream and create a systemic inflammatory response. This inflammatory response can increase insulin resistance and hence hamper diabetes control in our patients. Periodontal disease has also been found to have multiple other systemic inflammatory effects, ranging from halitosis to heart disease, respiratory disease, and many more. In fact, pathogens associated with an unhealthy mouth are the same as those associated with multiple serious systemic diseases, including but not limited to Alzheimer's disease, diabetes insulin resistance, adverse pregnancy outcomes, and even cardiovascular diseases. Apart from the obvious ways in which periodontal disease can cause diabetes control, there are a few more. First, it can lead to loss of teeth and difficulty in chewing, which will compromise our patient's nutrition, and this will lead to further poor diabetes control. Loss of teeth can also trigger feelings of anxiety, stress, and low self-esteem, all of which will negatively impact a person's quality of life. And a lower quality of life will further lead to poor glycemic control. Let me answer common questions that might come to everyone's mind. First, are the two diseases really linked? Yes, there is a bidirectional relationship that has been established, and a rise in one can lead to a rise in the other. Second, does periodontal disease really affect diabetes control? Yes, periodontal disease can cause systemic inflammation and enhance insulin resistance. Third, will improvement in glycemic control alone improve the patient's periodontal condition? No. It can prevent further progression of the disease, but it will definitely not reverse the disease. And fourth, can periodontal therapy really improve glycemic control? Yes. Periodontal therapy has been shown to have a positive effect in improving glycemic control by reducing A1C levels by 0.5%. To put things into perspective, this effect is similar to what is achieved by adding a second line oral medication. Look at this picture. What is the first thing that you notice? Well, let's take a closer look. Even though this person was also missing an eyebrow, I think one of the first thing that most of us noticed was his missing tooth. This just goes on to prove how important your smile is, how important a healthy smile is. And I think Dr. Ramakrishnan, I think he made a very good point about how important it is. Let's take a look at some familiar faces to prove my point. This just emphasizes how important a healthy smile is and how it can shape one's personality. Think of your body like a cricket team where all the organs are working together for us to win the game. If the batsmen and the bowlers are playing well, but if the fielders are letting balls slip by, we might end up losing the game. Similarly, if we ignore periodontitis, we might risk losing the diabetes game. Many people might argue that providing periodontal therapy for our patients would be expensive and time consuming, but let me put it this way. It is far easier, far cheaper, and far less time consuming to treat periodontal disease now than to treat the systemic and local complications that it might present if it is neglected right now. Incorporating dental and periodontal checkups and periodontal therapy can significantly reduce bacterial load and systemic inflammation and will help in preventing future complications. I believe that as we move into an era of providing personalized and holistic care to our patients, it is not just essential to provide periodontal therapy to our patients, but it is absolutely essential. Thank you.
Very well said and very good presentation, very crisp, very neat presentation and absolutely to the point.
Thank you.
So, yes, sir. Any questions here? I am in favor of this.
Well, I would be biased because I would like to hear Dr. Deepak Chudasma because she has already put the score on the scoreboard. Now he has to chase it down. So let us welcome Dr. Deepak Chudasma.
We gave so many names.
Wait, Dr. Deepak.
Okay. So
Dr. Deepak is a renowned diabetologist in Junagadh and a founder of Hope Diabetes Clinic and Research Center, Junagadh. He has completed his graduation from Jamnagar Medical College and his post-graduation from A. Ramchandran Hospital, Chennai in diabetes. He is currently pursuing his PhD in Parul University and finished his clinical research course from Oxford University, UK. He has presented many national and international scientific papers in the field of diabetes and contributed as a co-author in diabetes book. Your session starts now, sir.
thank you, Chairperson, for kind introduction. And out of box, thank you, Dr. Bansi sir, organizing committee and scientific committee for providing me this opportunity. So my role is very simple. Should a periodontal therapy or a examination in a standard as a part of diabetes care management plan? So should we make it a standardized? We'll just go through it and I'll put my perspective before immense audience. So diabetes management is a multi-nodal therapy. Like we say, diabetes education is much, diagnostic facility should be there,
individualized treatment should be there. It's not like fit one shoes to all. Prevention and management of complication by screening, by treating it, and lifestyle advice is the first priority. So whether periodontal therapy or a disease treatment should be a mandatory part of this plan. Despite the controversial connection between the periodontal disease and the diabetes, it should not be standardized as a part of diabetes management plan. Why? Why? Because there is a lack of conclusive evidence of the causal link. Why? Because some studies show that the link between the diabetes and periodontal disease, but causal relationships are not well established. Either the oral disease, which is increasing diabetes, or hyperglycemia, which has impact on the oral cavities. So some studies suggest that the periodontal therapy may marginally improve the glycemic control, but evidence are mixed up. Why the evidence are mixed up? Because in Diabetologia in 2011, one paper was there which suggests that the periodontitis and diabetes are two-way relationship. Existence of a two-way relationship between the diabetes and periodontitis, with the diabetes increase the risk of periodontitis, and periodontal inflammation negatively affect the diabetes control. Some another paper in the World Diabetes Journal in 2015, they also try to establish the relation between the diabetes and periodontal infection, where effect of the periodontitis and its treatment of the diabetes metabolic control are not clearly defined, and as a result of the study remain controversial. Another study, Diabetes Care 2010, effectiveness of the periodontal treatment on a glycemic control of diabetic patient, suggests that the presence of meta-analysis periodontal treatment lead to an improvement in the glycemic control in type 2 diabetic patient for at least 3 months. So this is in support of treatment. Whereas the effect of the periodontal therapy, like in the J. Collins Periodontal Journal, it suggests that the no statistically significant difference were found in the changes of HbA1c levels between the test and the control group. No surgical periodontal therapy improved the magnitude of change in periodontal parameter as compared to the control group. So again, it's question mark, improving diabetes with periodontal treatment, it's there or not. Okay, this is like a link we have to look after, but where is the resources? Resource allocation and financial burden, another aspect of treating periodontal disease in diabetes. So diabetes patients already face high cost of medications, blood sugar monitoring, treatment of other diabetes related complications like neuropathy, retinopathy, nephropathy, or cardiovascular or cerebrovascular. Almost now 72 millions of people in India suffering from diabetes in 2023. Average total expenditure of the patient per month is almost 1300, out of which medication expenditure is almost 1000. Only 271 they will be paying to a consultation or laboratory. Only a medical aspect is 80%. You can understand that. So if I say my patient to consult a dentist for your routine dental checkup, these numbers are not matching with that. They will not go for dental checkup if I suggest them to do that as well. So again, when the resources are for the doctor consultation like diabetologist, endocrinologist, or even MD clinician, then for the HbA1c, SMBG, or fasting PPBS, or RBS, or at least a creatinine, then the cost of the medications, and in spite of, if I'll add a dental consultation, then financial burden will be higher. So again, what are the accessibility and equality is also concerned. So universal periodontal therapy should be accessible to the health disparity. Many underserved population lack access to the dental care, and standardized therapy could further burden of these groups. Dentist unavailability in the rural area is a big concern. If we make it a plan in the standard care of treatment in type 2 diabetes, where is that availability of dentist in rural area like taluka level or beyond that. This is WHO data of India, where we can see over here. Yes. So in the policy, National Health System Response policies, the present third one, the presence of last one. So recognized as a national public health program. No, it's not recognized as a national public health program. If we see over here, the availability of dental assistant or any other dental technician out of 1 lakh population, there is 0. Only a 2 dentists available in 1 lakh population. So I think we are lack of resources and availability of dentist. Patient central care. As I said, one size does not fit to all, because not every diabetic patient experience severe periodontal disease, and the effectiveness of the periodontal therapy may be vary. Mandating it for all the diabetic patients may lead to unnecessary treatment, adding to a healthcare cost without guaranteeing an improvement in the health outcome. So, the regular monitoring of the blood glucose level, medication adherence, and lifestyle intervention are proven to reduce the complication and improve the patient outcome. So, prioritize your fasting PPBS, HbA1c, SMBG. Then, there is a insufficient evidence to suggest that adding a standardized periodontal therapy would significantly improve the outcome in all the diabetic patients. Yes, in 2025, in standard care of diabetes, they have recommended in people with diabetes should be referred to a dental exam at least once per year, but it's not mandatory. The diabetes care guideline do not recommend mandatory periodontal care. Another aspect from the dentist point of view, if I'll see the 100 patient per week and I'll refer that 100 patient to a dentist, then number of the patient in the dentist department will be higher, burden will be there for dentist. There are requirement of dental treatment in few patients which require like severe periodontitis is there or moderate periodontitis is there. They require more time to treat it, but because of the burden of this patient, they will have a lack of time, and in that lack of time, they might miss something in whichever the required patient are treating, right? So each and every patient I cannot send to the dentist as well. Potential for overall medication, like adding more standardized treatment may lead to over medication. Yes, dentists will prescribe something to them. It is the clinicians like duty to have something to their patient. The pressure to follow a rigid treatment protocol and lead a unnecessary procedure to patient who do not need them, ultimately reducing the quality of care. Periodontal therapy should remain an optional patient-driven choice. If patient has complaint, if you see something in patient, you refer to the dental. Pattern of disease and therapy for a diabetes, along with the impact of generic prescribing, a cost of treatment among the outpatient in tertiary care facilities where the pill burden remain high, adding more pill will improve the patient adherence? I don't think so. So, in the concluding remark, while a periodontal health is important for diabetes patient, I don't say it's not important. It's a very important. There is insufficient evidence to support the standardization of periodontal therapy within diabetes management plan. We should focus on the evidence-based, individualized care that prioritize patient's unique need, avoid unnecessary finances and treatment burden as well. Thank you so much.
Well tried, Dr. Deepak, and well played. A big round of applause for Dr. Deepak. See, when you are playing in Gujarat, so the Gujarat Titans are favorite. Okay. Any other team which plays, they're not the favorites. Having said that, the arguments which you have tried to put forth are praiseworthy. However, there are a lot of contraries to it. Uh, one of the fact that I just want to put to beyond the debate is over. Yes, we don't want to stretch because the next session also has to go. Recently in December, we had a DIOH group workshop in Delhi, chaired by Dr. Sangeeta. And one of the highlights of the workshop was that we conducted a training program for the medical practitioners on oral health program. Now, the fact is, we know and we think that we know that the oral cavity, but the fact is that many of our medical fraternity brothers and sisters are unaware to see the actual disease happening. So when I took the workshop, so when they were able to see what exactly a disease looks like, that opened the eyes. So the fact of the matter is, if we refer, the probability of detection goes higher. So as Madam said, I don't think that this is again a point of debate also. So the whole idea of diabetes oral health group is also to bring this and build these bridges around that we as a dentist, we definitely are sending the patients whenever we find that the patient is diabetic to a diabetologist, but the reverse is not happening. So it is an earnest request that kindly peep into the mouth if possible. And also we have developed a tool of oral examination with a few questionnaire which we floated, and around 6 to 7 diabetic centers in India we ran the pilot in order to find out whether by the help of these few questions they are able to see and assess the oral health. And we conducted, I think, more than 1200 patients. We got the support, and it was a fantastic response. The response time was 2 minutes or less than around 2 to 3 minutes, and they were able to assess. So we are working towards it so as to build this bridge that whenever a patient who is coming to a diabetologist, please make an effort at least to send them to a dentist or a oral health practitioner. It is possible that many of the things that they will see which you have failed to see. Thank you.
So I have one more point to add. The only point that is justifying in your case is the evidence based. The evidence is not there, that's why it should not be standardized. Okay. The reason that you gave is, first of all, the cost effectiveness. So when you refer a patient for screening, so ऐसा नहीं होता कि all the patients हम start कर देते सर्जरी करना. We just screen them and we guide them. So because dentistry is not expensive, it is. In stage पे आके if you take a missing, so अभी मैम has to नहीं sir has to if you don't take it, so that is going to work. And second point that you have is lack of time. So we didn't sell the so it's just saying this. So so they are you have to diabetes which then the physician's responsibility that we got the least if it is required. So thank you so much. And it was an amazing session. We had to love
Forward to that. Even I am in favor of yeah. This is true. This should be. But like a base level, we are missing something. Yes. Right? We are missing something. I am a diabetologist. I see so many patients, but each and every patient I cannot refer to dental. Yes, if patient something has symptoms is there, I do refer. So I do have space. So many in my clinic, I offer my dentist fellow to come and see. You give FOC consultation who do not have any disease. I give you my old patient, but FOC for all the patient who do not have anything. Consult who have some disease like periodontal disease, but nobody is ready to sit there for this close.
Actually, so what was that I want to answer. My wife is a linguist. I tell my patients to go get screened. Sometimes she will see freely also, but they're not because they don't have education about oral cavity and other things. I think our discussion should be like whether oral screening should be the mandatory for a diabetic, and because AD also screening okay actually. Yeah. Screening is there. What is that? Not periodontal treatment or something. No, screening is very important. Yes.
you just tell them that this is the problem that you're facing. Now to get the treatment or not, it is obviously patient's call.
But screening is
The screening is important.
Right.
Yeah. See, if we have it in a list, and we need to tick all, then maybe there is a probability 80% would do. But if we do not have it in a list, maybe 10% would do.
So sixth complication is periodontal disease, diabetes mellitus. It is proven and documented. So now start referring.
Okay, this is wrap up time now. Can we have the next last part? PPT ka set kar de, please set kar do. Start okay. 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 Again, we have discussed ample, but still we would like to fall back on the policymakers. I'll quickly go back to the ADA 225 again. Dental health professionals should be included in the diabetes care team. We are not there to debate. Detection from the clinician side is important. Why? Early you detect, early you're going to be referring out. This is what we are talking about. Early we refer out, early we catch the disease, and probably we cut down the dental expenses because